and thanks to the organisers for asking me to speak today. So, as you know, we're going to be talking about the different approaches for TAVI. So what I thought I'd do to kick off is just set the scene a little bit. We've heard in broadening the field and options for our aortic stenosis patients, we've heard about the importance of the multidisciplinary team, and it's clear that to deliver transcatheter therapies successfully in general, we have to pay rigorous attention to patient selection and use whatever means we have to ensure optimal performance of what is a complex implantation procedure and apply close attention to the post-operative care. One of the key ingredients that has emerged, and you've heard a nice talk this morning from Anita McNabb about the role of imaging and interventional in transcatheter strategies, is the multimodal imaging nature of this procedure. You will, of course, appreciate the importance of assessing the anatomic and physiological suitability of the patient for the therapy, and exposure and visualization is critical. Sorry, I don't know where I'm causing some interference there. Clearly, that's the only explanation. Thank you. But falling short of having the direct surgeon's eye, we rely on good quality imaging to provide us with the necessary information. And you're aware of the 2 valves that are currently commercially available. A number of others are in the pipeline. And I won't run through the evidence. It's already been mentioned. We have clearly established role now for these devices with good rationale. More data will be emerging soon. But clearly there are unresolved issues also. And one of the key ones is that of vascular complications. The rates of vascular complications for TAVI can range from 6 to 15%, and it's no big surprise when one considers the patient population that we're treating. As we've heard about, a high advanced stage group, significant comorbidities, peripheral vascular disease figures. And so, whilst the trans-femoral approach is the first default approach, if you would like, when considering these technologies, they're not without their issues, and there are a number of approaches which have been developed to treat patients who aren't suitable, and we'll be hearing about them today. The other one I would just add on is the carotid approach, and at our centre we've done recently 6 or 7 cases successfully in patient groups who are unsuitable for femoral approach. So, when looking at multimodality imaging goals from a pre-procedural perspective, there are some key aspects we're looking at and key aims we have. The first one is, of course, ensuring patient suitability for access site. Secondly, that we can deploy the device safely and successfully, that we're selecting the right device size. And this whole pre-procedural assessment really seeks to contribute to that overall procedural plan. So from the transfemoral perspective, there's no doubt, given the high complication rates, that the higher level of imaging and modality that you use, the lower your complication rates. We want to get as much information as possible, but the standard first basic assessment in these patients is angiography, and all patients will undergo distal abdominal aortography and iliac runoff. And it's good at giving a basic assessment of the peripheral vasculature, gives us an idea of the lumen size, but it's not great when looking for more detailed information in terms of disease burden, calcification. And CT has emerged as the single most important modality, really, in terms of assessing these patients further. And I list the role of CT. Obviously, it's beyond just looking at the access site. We use this also along with echo and other imaging modalities to look at the aortic root anatomy, arch anatomy as well. And it's clear that using standardized CT protocols will reduce your morbidity and mortality, and using standardized protocols with 3D reconstruction allows us to identify those patients who have high-risk features from a transfemoral approach. And so in particular, we're looking at severe angulations, marked calcification, above 180-degree calcification, a lot of atheromatous burden, and severe tortuosity, which caution us against the femoral approach. There is a minimal vessel diameter we look for. With the reduction in sheath sizes, it's likely that this is going to become some sort of moving target. And I think if, from an imaging perspective, there are unfavourable aspects, then that's an indication to look for an alternative approach. So, having established pre-procedurally that the patient should be suitable for a transfemoral approach, our imaging guidance during the procedure is with the specific attention to puncture site and then sheath advancement, and then at the end of the procedure for removal and haemostasis. And we use mainly fluoroscopy with the benefit of our pre-procedural information, which is guiding us with particular attention to the anatomy of the femoral bifurcation in relation to the inguinal ligament. We have two access points. One is for our actual interventional procedure. We can use a contralateral access point to actually guide our puncture, and different approaches are taken. This is a pigtail that's been brought from the contralateral side, and we can make a fluoroscopic guided puncture into the femoral artery at a suitable point. Ultrasound guidance can be very helpful, and if CT pre-procedurally has identified that there is a segment of disease or calcification to avoid, then we do use this to improve our precision and accuracy when making femoral puncture. And then, having gained access, we obviously have to pay attention to how we're going to close our access site at the end of the procedure. The Prostar closure device is a suture-based device using nitinol needles. And again, this is all fluoroscopy based, so I don't know if that played at all. And then really, it really is fluoroscopically driven throughout from, with respect to the transfemoral approach, and serially dilating with sheaths before going to your actual delivery sheath is often worthwhile in order to minimize trauma, and doing it under fluoroscopy so you have some sense of the movement of the aorta and the pressure that can be exerted when advancing your sheath is important. Now, of course, once the sheath is in, if you have caused any damage, the sheath is usually occlusive. We're anticoagulating our patients, but it's not until the end of the procedure, when we withdraw the sheath, that vascular complications come to light. And so at this point, there has to be a high level of attention for the possibility of a tear, a leak. And it's often useful to take, again, a contralateral access to your artery. So when you withdraw the sheath, if you are worried about vascular injury, you're ready with your peripheral intervention kit to take the necessary action. So this is post-Prostar, and you can see this is the point at which the sutures have been tightened after sheath has been removed. These are some examples of complications that we can encounter. Sometimes can be treated simply with relatively conservative method of balloon tamponade. More significant laceration now, which required tamponade and then further stenting, which should come up. And so it's important, obviously, to have that level of preparation before you even take the sheath out. Post-procedurally, again, once the procedure's over, maintaining that high index of suspicion is important, and the key imaging modalities here, if we are at all suspicious, ultrasound and obviously CT for any level of significant bleed that might be considered. So that's short and snappy talk, just taking you through the key elements for a transfemoral approach. Careful assessment, absolutely crucial. This is a theme you're hearing about throughout the day. In order to optimize our outcomes, it's crucial to optimize our visualization, and using all the multimodality imaging available is extremely important in achieving this. Maintaining good attention to detail and being prepared in the event of vascular complications are key features for trans-femoral approach. Thank you.
Why are you using fluoro to cannulate the vessels? And I think the nice guidance is that every vascular puncture should be undertaken, any access should be done under ultrasound control. And that's quite anathema of the catheter.
It is.
But we moved to that. There's no doubt in our mind that it reduced our vascular complication rate and also the rate of successful deployment of the Prostar, because you're able to avoid anterior calcification of the vessel, cannulate the middle of the vessel. So I just wonder what your views are on that.
No, absolutely, and that's an appreciation that we've also developed over our experience. So we started off very much with fluoroscopically driven punctures, and we still do use fluoroscopy a lot. But there's no doubt that that has had to be refined as we've become aware of the complications. And ultrasound guidance we're using increasingly now for better precision for precisely that reason.
So, any other questions for Ma'am?